it's what I've discovered is probably the main cause of all the issues I deal with as a dentist. Decay all originates with the mouth's inability to clean itself. If the tongue is tired or the lips tired, you don't have a natural washing effect. So even from decay, breathing issues, sleeping issues, small mouths, crooked teeth, poor postures, all these things are all relate back to that tongue not being in the palate.
Yeah. How early are you able to diagnose that? And
to be honest with you, the time you want to pick it up is the very first feed in the hospital.
Yeah, I think for me, and I agree with you totally there, is because if the first feed goes well, there's a level of confidence that comes with that mom, because then the next feed will also, you know, she's already feeling reassured. And if there's nobody to help her and say, oh, okay, the reason you're struggling to latch is because of this, but we can fix it, then we're already on the right path.
Absolutely. So to me, a pediatrician, that the child should come out, the pediatrician to get the baby from blue to pink. And then the next thing is to make sure that that child can get its first dose of antibiotics, which is the breast milk, the colostrum coming through, get its bacterial flora into its gut, because that's going to prime the child's immunity for life. It's a probiotic for the bacteria the child should have picked up in the natural birth process. So if you don't have a natural birth and colostrum to feed the bacteria that's just been, the child's been inoculated, the sterile baby has been inoculated with, you're going to have a poor gut bacteria for life to re-establish good oral health, and all your immune system is reliant on your gut bacteria. I know now they do with Caesar babies, they even swabbing moms and then inoculating the child with the vaginal swab that they used just to get that initial. Now the first 3 days of milk, the colostrum that's come to, that is probiotics. It's not food for the baby. It's food for the bugs that's
Absolutely
there to help with the digestion.
I can't tell you how refreshing it is to hear a dentist talking about the importance of breastfeeding and the microbiome and the essential properties of colostrum. It really is great. But as you say, it's the long-term impact that we are not aware of and why it's so important.
Yeah, and it's embarrassing that we don't know about it because we're not taught this. It's not our department. You know, we've put medicine into such boxes.
Yeah, I wonder if maybe you can share a little bit with us about the importance of the tongue and why the tongue is so important to being able to feed effectively and breathe effectively, because also helping moms to understand that breathing, sucking, and swallowing are a developmental skill and how important they are for effective feeding.
Yes, and how the difference between a suck swallower. Now, when you see there people who swallow and their faces contort. I've got a beard now, so I'm not the greatest. And a throat swallower, somebody whose face is still and they're using their throat muscles as well. The difference in what your brain has to do is two completely separate cranial nerves that supply those tissues. So you actually have to learn the reflex of doing that, and to unlearn it is terribly difficult. By the time a child's 4 or 5 months old, you know, we're getting a lot of babies at 4 or 5 months coming in for tongue ties. And I say to the moms, well, you know, I'm a monkey with a spanner. I can cut them for you, but who's going to teach that child to swallow correctly? And you've got to get to craniofacial therapists. You've got to get to chiropractors who do craniofacial therapy to relearn the correct reflexes.
If there's a tongue tie or a lip tie, which is essentially a piece of tissue that is hindering the movements or the natural movements of the tongue, impacts the feeding. So how should the tongue be working if there's no tongue tie or lip tie?
Okay, so the tongue tie is more crucial for this, because the tongue tie at the bottom, it can be anterior or posterior. The anterior, if that's the tongue, the anterior part prevents the tongue from moving forward out the mouth. So inside the mouth, they're moving in a forward direction. But the posterior tie stops the tongue from doing that lift at the back. If you look at the tongue, you see that indentation in the middle.
Yes.
That part must lift. You need that to start the peristaltic wave. You need the forward
of the tongue.
Yeah. So if you're tongue tied in the front, nothing happens. But you can have a posterior tie without a front tie, then the tongue doesn't lift. If you don't start the peristaltic wave there, it doesn't go all the way. It's a wave that starts there and goes through the gut. So it's taking the milk down the alimentary canal. And if you don't have a good peristaltic muscular reflex, that's the child that's getting reflux all the time.
So what you say is that the peristaltic movement of the tongue actually goes all the way down the gut.
It's a continuous wave, like a big breakdown starting in the mouth and ending at the other end.
So if there's no peristalsis in the tongue, that is what's causing the reflux, because there's inadequate peristalsis going down the digestive tract.
You're using your lungs to create negative pressure to suck. It becomes a sucking action, not a milking action.
So yes. That is the difference with the baby with a tongue tie, is that they suck differently to get the milk out. We shouldn't use the word suck. There should be no suck at all. Milk flows from a breast if the breast is stimulated. That's why moms with no babies are leaking all the time. If they hear the baby's crying, the milk starts to flow. Milk automatically flows from a breast. It's just the baby's job to take the milk down the alimentary canal. You don't create a pressure differential. However, with a bottle, there is no flow. You have to suck the milk out of a bottle. And that's where the bottle's causing two problems. One, you're starting to use your facial muscles, and there's 160 odd of those that have to work. And my little saying I tell the parents, moms, if you go to the Spur and order a double thick milkshake and you try and wolf that milkshake down through a straw, see how far you get. It's hard work. The babies fall off the breast exhausted before they've had their full feed. And at best, they'll empty the front part, the thin part of the milk, and won't get to the posterior fat milk. It's just, yeah.
And to compound the issue, they're sitting on the end of the nipple if they're lip tied as well. They're sitting on the tip of the nipple, squashing the ducts flat, and then trying to suck the milk through the hose pipe that they're busy crimping.
Yes.
So you've got
to. Why the nipple flattens like that, so we often see that.
And the poor mom's getting a love bite every time she feeds, and she's not happy, so she's not making more milk. And then the milk, if she's not having pleasure when she's feeding, she's having pain, then the milk's not going to flow. It's, she's going to. So, then the mom gets the, oh, you have no milk, if you've got a short supply. You get a baby, you get milk. There's milk for the baby. But you need that milk production to be stimulated. And that means you need to have pleasure when you're feeding, and you can't be feeding every hour. If a mom's exhausted, she's also not going to have enough supply.
Yeah, well, I think you've just highlighted such an important difference, is that if there is any hindrance or tongue tie or lip tie, it changes the way that the milk transfer happens, and changes the way that the baby's mouth is, or the way the baby has to get that milk out. Also, then her milk supply drops, got a fussy baby, and then she thinks she can't breastfeed.
Yeah.
And now, if you can maybe just tell us a little bit about that. So now we know if there's a problem, if there's a fussy baby, which is very often diagnosed as being colic, which we know there's always something behind the colic. So poor milk supply, cracked nipples, painful breastfeeding, fussy baby, colicky baby, all of those things. If we had to check and see that there is a tongue tie or a lip tie or something, how do you normally treat that?
All right, so the process is, look, I'm not the first line of diagnosis, because generally my patients all have teeth. So nobody's coming. Because nobody's coming to me for advice on breastfeeding. I'm very fortunate to be in this position that I'm in, because I own a laser, one, and two, I had an aunt that was a breastfeeding consultant. I went to numerous breastfeeding consultancy lectures and courses just to understand on how the mouth is working, how breastfeeding is working. There was only one lecture in all those events that I went to where a dentist actually came and spoke, who was knowledgeable in this. But other than that, I'd never heard about the mouth as far as my profession is concerned, involvement. But so I landed in this position. I didn't choose to go down this route. It sort of it came at me. But it's a privilege because it's the only treatment I do where I have a procedure which takes me probably 3 minutes to do, and the baby goes straight onto the breast, and there's an instant result 100% of the time. It's a wow moment for the mom. It's like, oh, is that what it's supposed to feel like? And it's the most, yeah, the babies are crying. It's awkward to deal with. The first 20 times I did it, I think I was wet with perspiration, you know. But because you're dealing with a crying baby, it's first probably procedure, and the mom's a little bit unsure, is this too soon or is it too late? When the results have come in over the last 6-7 years, it's now undeniable. It's an instant fix. But I don't work alone. So the way I ideally would like to come is that the baby would first go to a lactation consultant because there's a problem. Have a look in the mouth and say, there's a lip tie or a tongue tie. But not all lip ties and tongue ties will cause a problem. If the child can latch and feed, then it's fine. You know, is it necessary to go and do something then? Not from a breastfeeding point of view. From a dental point of view, I think that it's also necessary to do something then. The sooner, the better. Ideally, we want to see children in the first 2 weeks. That's the time you want to do those releases. Get it in, get it done, and then they don't learn the bad habits, the sucking habits, and not the feeding habits. And also the work, the releases are much easier. The child, we keep them stiller. That, you know, that they're so new. There's very little bleeding. Normally the
healing.
The ties are very small, but that's not a problem. It's actually a benefit. You know, I put on a pair of loops and I can see them clearly, and it really takes seconds to do. At 3-4 months, children should be having solids being put in their mouth already. They should be chewing on hard pieces of broccoli and cauliflower and things like that. Again, very important to get that done for the muscles and the face to develop properly.
Well, I think at 3 to 4 months is a developmental, they're already putting everything into their mouth. So they don't know the difference between a plastic toy and a carrot stick. But definitely they are learning that gross motor skill of bringing something to the mouth, as you say, sucking, chewing, learning how to swallow. And they're not taking the whole, it's not like they eat the whole carrot stick. They will usually lose interest halfway through. But they've got the benefit of that.
You know, like a piece of broccoli or a piece of cauliflower or carrot to chew on at 3-4 months, although they're not physically chewing it and ingesting the whole, the hard substance, they will never eat a cooked vegetable again. You can give them purity, mushed up purity, they will not touch it. They know that their body knows the difference between raw, healthy vegetables and something that's been cooked and salted to death. But, you know, we're in a culture where babies are fed porridge probably their whole life. They go from milk to purity jars and stuff. That's not food. You need to use your jowls for your face to develop. So we've got this epidemic of shrinking faces that are just getting smaller and smaller with every generation. Teeth getting skewer. The way I got into this was arguing with my aunt about why the children have all got tonsils and sinuses issues and stuff like that. And she says, because they're all breathing through their mouths because they're taught to sleep with their mouth open and their tongues don't seal the mouth off and they're not breathing through their noses. Nobody understands how important nose breathing is to the body. Most of us are sick because we breathe through our mouths, and the nose is a filter. Every bacteria, virus, fungus, spore is taken into that nose. The air is turbulates around that nose, and these little cells in the tissues called mast cells pick up these germs and bugs, and immediately your body develops antibodies and immunity to the bugs without you getting sick. A mouth breathing child is going to take those bugs going straight to the lungs. So if you want a child, a baby that's going to have tonsils, adenoids, grommets in the ears, have allergies to every pollen and stuff like that, keep their mouths open and don't close their mouths when they're sleeping.
Well, I think it's important for the listeners for them to know that babies are born naturally as nose breathers. That's our default setting. So if they're not nose breathing, then we need to look at why.
They train to nose breathe only on one place, the breast. Because when a baby's feeding correctly, it's breathing through the nose comfortably, getting in all the oxygen it needs, and its tongue is still providing the pressure on the palate. So without feeding, we swallow 3,000 times a day. We actually swallow our saliva 3,000 times a day. That's 3,000 times your tongue should be pushing in your palate and making your jaw grow this way. The occupational therapists at school have their careers to thank for the fact that we're putting bottles in mouths instead of breasts.
So that, I think I also want to mention something that you talked about earlier when going back to baby-led weaning and the soft food that we're giving. I think that relates a lot to the fear that we are all living in at the moment. And certainly a lot of the moms that I work with are afraid of solids. They're afraid of their baby putting things in their mouth. And that's why they are defaulting to this mushy food and soft food and purees and everything. And there's a misunderstanding of the baby's natural gag reflex and its ability to do that, and how we can train that with the baby-led weaning. And I wanted you to maybe just explain a little bit about that, just to reassure moms and explain to them the importance of being able, how their babies can already do that, and how we need to help them develop that skill.
Okay, so this is the difference between being what I call a suck swallower versus a chew swallower, and this knowledge comes straight out of a textbook written by John Mew called "The Cause and Cure for All Malocclusions." So what happens is your face is controlled by your fourth cranial nerve, your facial nerve, whereas your throat and your tongue are controlled by your fifth cranial nerve, your trigeminal nerve. So your brain has to actually learn. If you become a suck swallower due to dummy, bottle, thumb, whatever it is you're sucking, or even incorrect latching, sucking on a breast instead of feeding on a breast, your brain is actually wired to use your facial nerve as its swallowing function. Here's the problem with the facial nerve. It's using negative pressure to get the food or the milk from out to in. It's a suction that's happening. To create suction, you have to have your airway open. So a choking baby is a baby that chokes on something, is a baby who is sucking the food down and not swallowing correctly. Food cannot go into the lungs. You can't choke if you swallow correctly. But if you suck swallow, that's open, and then the food goes down the wrong pipe. And how often do we eat a grain of rice, or we're eating too quickly, and a grain of rice or a piece of bread or a crumb of bread goes down the wrong pipe, and we spend a good 5 minutes trying to cough it out? Or choking incidents, food going down the wrong pipe, people talking with their mouth full and then they inhaling through their mouth as well. You see, they're trying to breathe, talk and with food and stuff, and they're not breathing through the nose while they're chewing in a closed system. But once you swallow, once you take the food from mouth to stomach, that's swallowing, your airway should be closed. And the only way it does it is if your neck muscles are working.
Babies who are bottle feed, does it change them from being nose breathers to mouth breathers? Or are they still nose breathing when they're bottle feeding?
It simulates the breast. No, not a chance. Milk flows out of a breast. Like I said, a mom, if she hears the baby cry, the milk will start coming out too. That's why they got to wear the pads and the shields. Milk wants to come out of a breast. There's positive pressure pushing milk out. Nothing. If you turn the bottle upside down with nobody on it, no milk's coming out of that bottle until it's sucked out. And it's not the same action at all. Also, the teats are generally big and wide, so it's keeping the tongue out of the palate. You haven't got the same action of the tongue forcing the palate. Now, things are getting better. I see there's a new pacifier out that the Mayo Health Group have brought out that actually helps stimulate. It helps the tongue push into the palate. I'm not sure. I've never seen one. I only saw it a week ago or so on somebody posted it on the website. But really what you want is a tongue in palate posture, and you want a throat swallow. You want a proper throat swallowing reflex to form. And that only, at the moment, there's only one organ on earth that can cause that to happen. That's mommy's breast.
For me, it's important for moms to just have this information, because there's so much disappointment around it when they are unable to breastfeed and when they don't get the support they need to breastfeed. Because for me, when a mom is unable to, it's not because of something she's done or hasn't done, or something the baby has or hasn't done. It's because she hasn't had the right people around guiding her and saying, this is the reason you're struggling and this is how we can help. And making sure that they know that there is help out there. And if something isn't working with breastfeeding, whatever the problem is, it is usually fixable. I really, truly believe that 98% of breastfeeding issues and challenges are fixable if we see what the cause is. And sometimes it's something as simple as they're changing the position. But very often, we know now that it is something anatomical, but even that can be changed.
Yeah. And this is, I honestly, I look at the moms that come, I feel for them. Yeah, you've got a lady that's probably got a little bit of postpartum depression. She's sleep deprived. She's worried about her newborn life, not picking up weight because there's all these little charts that she has to tick the boxes for, or the pediatricians go, man. The pressure's unnecessary pressure. And then she gets blamed when the child isn't. It's her fault. She's not making milk. She's not got enough. Her breasts are the wrong shape or the wrong size. It's
none of that. None of that.
The fault's all with the baby. It's not with the child. And I can tell you, I think 70% of the time, it's a tongue and a lip tie. End of story. I've seen a lot of babies that have gone, and that's when they come. They go to the lactation consultant who teaches them to latch properly, does the sort of little exercises and the Melissa Cole massage techniques or whatever it is, does all these things, and there's no result there. Then they look inside and go, okay, but it's lip tied or tongue tied. It's sort of got to be done together. Those things, those exercises are more important than what I do. But if the hindrance isn't taken away, the exercises won't help. And if the hindrances are taken away, then the exercises are even more crucial. Nobody would go to an orthopedic surgeon and have their knee corrected or their knee replaced and the hip replaced without seeing the physiotherapist to have the rehabilitation done. It's not one or the other. You need the teamwork to happen.
So if you could just explain the difference between the way you do it, using your laser, and how quick and easy it is, and how it works and what happens afterwards. So the procedure from diagnosis to sending mom home post-operatively.
The difference is if you use a scalpel or a scissors, if you're doing it at birth, it's not that big an issue because it's quick and there's not a lot of bleeding for some reason. That's how tongue and lip ties have been cut for centuries. The best place to treat the baby is in their car seat. Either my nurse or daddy or granny, whoever comes with mom, will hold the baby's head still with their hands and their thumbs on the chin. I have a little frenectomy fork. You just push under the tongue and the little frenum goes up that slit. Once it makes a little string there, I literally just touch the string with this diode laser, which has a setting, the correct setting for the laser, and it just separates. And as I'm holding the fork, you'll just see the tongue move away, literally start to move left and right. And then I run my finger over the tongue area, and all I'm feeling for is that I'm not jumping a fence. So if I sweep under the tongue, it must feel like I'm not hopping a hurdle. There's no hurdle there. It almost feels smooth under there. And then I show mom and dad how to do that because it's crucial. The laser, it is a cutting tool, but it's not using any trauma. There's no, if you use a knife or a scissors and that's your frenum, you're cutting everything plus the frenum. So there's lots of bleeding. It needs stitching. sometimes. There's a lot of work involved. So generally a child needs to almost be put under a general anesthetic or a partial sedation to do the work, because they're moving around too much. With a laser, they can move all they want to. As it's cutting the sinew, it's cauterizing the area, it's sterilizing the area, and the laser itself has healing properties. And it's the one problem with the laser is that it heals too quickly. It wants to reattach. The scar that forms there will act like a new frenulum and pull things together unless it's massaged. So we tell moms after the procedure, on that day, nothing has to happen. And then after every feed for the week following the procedure, after every feed with the mouth full of breast milk, just to take the little finger and sweep under the tongue and under the lip. A nice white scab will form there. It's like if you have a scab that gets wet, it makes that white fibrinous patch that will form there. That has to be swept and stretched regularly after every feed for the week following surgery. And then everything heals up fine. I've never had a case of an infection ever, or like that. The lip does swell often. On day 2, it will swell up and then it will go down on day 2 as well. Other than that, there's never been any complication other than reattachment.
The benefit of using the laser is that baby can literally go onto the breast immediately after the surgery or the release, and the mom will feel a difference straight away because now the tongue is mobile. So
yes, it's sore. I always tell mom the baby's going to cry, and the louder it cries, the more I can see. So, but the minute the baby hits the breast, it's forgotten. All's forgotten and all's forgiven.
Exactly.
And the best post-operative medicine is breast milk. So if we do get moms who are 3-4 months down the line and are already using formula, and they come in to have the tongue and lip tie done because of the baby taking in a lot of air, and I don't like the word colic. Colic is that's fine. Colic is just another word for a tongue tie, as far as I'm concerned. There is no colic, because if the child's taking in air, that's what's giving them colic. If they're taking in air, it's usually a lip tie. They're pursing where the front of their lip isn't flaring. That opens up the sides, so you hear the click, 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 and you see the milk leaking out the sides. That's a lip tie that's usually doing that, not a tongue tie. And again, you just take that away and it's instantly solved. It's chalk and cheese, even on a bottle. So a lot of the 3-4 months old babies that are on formula are coming.
Sure, there's been a lot of stuff that you've covered with us today, and I know for a fact that it's going to be incredibly helpful for pregnant moms and moms who've got younger babies. And I just want to thank you so much for your time. Is there anything you want to add? One last little snippet of pearl of wisdom for moms about breastfeeding, feeding, sucking, swallowing, breathing?
All right. So I